So, all right, well, welcome everybody to Geriatric Grand Rounds, and a few announcements as always before we start. So next Grand Rounds is November 5th. Our presenter will be Dr. Laura Scherer, Assistant Professor in the Division of Cardiology. And our next Journal Club is going to be November 12th, and our presenters for that will be Drs. Megan Goss and Jeff Wallace. Other announcements, after today's Grand Rounds, you will receive an email with a link to the recording of the presentation, and also included in the email will be a link to an online evaluation, so very helpful if you guys can fill those out. Please submit questions either in the Q&A box or the chat box anytime during the presentation, and we'll get to those best we can. So I'm really excited to introduce our speaker today, Dr. Peter Ubel. Dr. Ubel is a physician and behavioral scientist who uses tools of decision psychology and behavioral economics to explore topics like informed consent, shared decision-making, and healthcare cost containment. He's authored over 300 academic publications, the majority of which involve empirical explorations of design psychology as it pertains to healthcare. He's written for numerous publications, including the New York Times, Los Angeles Times, The Atlantic, New Yorker, and is a regular contributor at Forbes. His books include Pricing Life, Free Market Madness, and Sick to Debt. And you can find his blogs and other information at peterubel.com. We were hoping this was going to be an in-person seminar in conjunction with our Data to Value program, but unfortunately circumstances changed, but we're really lucky that Dr. Ubel is able to join us remotely today. And so I'm going to turn it over to Dr. Ubel. Welcome.
Well, thanks a lot, Carrie. And one upside is I can present in my slippers, so that's one advantage of this format. I'm sorry it won't be as interactive as I normally like. I don't normally like to just blab. But I will try to be brief, and then we have time for a Q&A. I'm going to open up with a question. I want you to all think of how you'd answer. Suppose you could make one change in healthcare policy in the United States that would better empower patients. What would that change be? Many times when I've asked this question, I get things like universal insurance. I get, let's have decision aids in the waiting rooms. Let's teach clinicians how to elicit patients' preferences better, things like that. But there's a different way to empower patients. It's one that actually, we saw a couple bills before the 2016 election. We had a couple bills in Congress that were designed to empower patients. One was called the Empowering Patients First Act. The other was called Patients' Choice Act. Both were in the House of Representatives and were put together by Republicans, and both of them actually tried to get more people to have higher out-of-pocket healthcare costs, with the thought being that would empower them to act like consumers thinking about the cost and quality of their care. So the theory being that if people get all the healthcare they want for free, they just don't scrutinize the cost and quality of that care, especially the cost part. And then we end up with a very high cost system. So the Patient Empowerment Act and the Patient's Choice Act, whatever, I've already forgotten the names, we're gonna get more Americans to have high deductible health plans with high out-of-pocket costs, high out-of-pocket maximums, things like that. And now they'd all of a sudden have to really look carefully at their medical care. That careful scrutiny would lower the cost of medical care and potentially raise the quality. That was the theory. Just let me tell you a quick story, because in my book, Sick to Debt, I try to explore these health policy debates about out-of-pocket costs, but I try to ground them in the experiences of real people. And one of those people was Chris Tribble, who's allowed me to tell his story. And Chris was, when he was 39 years old, he worked for a trucking company in North Carolina. When he was 39 years old, he was diagnosed with stage 3 colon cancer. He eventually ended up at Duke University for his medical care, where he saw my friend and colleague, Yusuf Safar. Yusuf is one of the people who has been worried about the financial toxicity of medical care, that high out-of-pocket costs are harming people like a side effect. So Yusuf saw Chris in the clinic, and with the surgeons, they planned a course of chemotherapy that would shrink the tumor before they could then remove it surgically. Got sirens going by me, sorry for that. They did that chemotherapy. Tribble he tolerated it well. The tumor shrank, got into surgery, but in the operating room, they found that the tumor had spread to the liver. It was now stage 4, and it was not curable anymore. He came back to a clinic to see Dr. Yusuf, and Yusuf tearfully told him that there was not really a chance that they saw of curing it anymore, but given the good response he had to that initial chemotherapy, maybe they could go back on that chemotherapy, slow the tumor down, and who knows what new developments would come, et cetera. So you can, I'm sure many of you have been in that situation where you're trying to give someone really bad news and give them some hope on top of it, and hope isn't completely unrealistic. So that's what Yusuf was trying to do. At that point, Tribble looked at his doctor and said, I can't go back on that chemotherapy. Why? Because I basically spent every last dollar I had paying for that first round of chemotherapy. At that point, Yusuf realized that he'd given Tribble a pill that would be very convenient to take, but that was very poorly covered by his insurance. When there was an equally effective chemotherapy that would have been intravenous, would have required him to come into the clinic, but would have been very well covered by his insurance, and would just as good, would not have bankrupted him. Here he was, like one of the leading experts in the financial toxicity of medical care, and he had just bankrupted one of his patients without being aware of it. That's the free market at work, or that's the high out-of-pocket and patient empowerment illustrated. It's just one case. I don't believe the plural anecdote is data, but it does illustrate that even people with a lot at stake, life and death at stake for one, but all of his savings at stake, wasn't knowledgeable enough or empowered enough or something to be able to ask his doctor, is there a less expensive chemotherapy that would work for me? So what I want to talk about here is I want to talk about whether this move towards getting more people into high out-of-pocket health plans is working, and whether it could work. It has been happening underway, even though neither of those Patient Empowerment Act, Patient Choice Act came into law. The fact is, most employers are starting to get more and more of their employees to get into these high deductible plans, to where a third of Americans are in them already. And so this is the American healthcare system now for many people with private insurance. It's high out-of-pocket cost. It is the system for many people in Medicare who can't afford supplemental insurance. It's high out-of-pocket system, and I want to talk about what's working and what's not working with that. So we'll start with the idea that people are choosing to be in high deductible health plans, and they're doing it because they made some informed choice about risking out-of-pocket costs versus having lower premiums. Typically, if you go into an insurance plan that's got high out-of-pocket costs, it probably costs less per month. That's the trade-off. And so an informed consumer would think, am I willing to save a little bit each month at the risk of having high out-of-pocket costs? Somebody who's really sick to begin with should probably not be in that high out-of-pocket plan because they're guaranteed to get a lot of out-of-pocket expenses. And so they should probably pay more per month in order to have less out-of-pocket costs. You all probably know this well. Problem is, most people choosing insurance plans don't know that very well and are too confused to make the right choice many times. A lot of times when people are described, they get a description of an insurance plan and find out that one of them has a high deductible, they think that's a good thing because that must mean they're deducting more from the price. So even the words, the language can confuse people. And even when we've given people definitions of what a deductible is, we still find about a quarter of people confused about it and thinking that higher deductibles are better than lower deductibles, all else equal. Mary Polity at Washington University in St. Louis has led some studies on that and low-income people around that community, and finds it's just really hard to get people to understand that language. Same thing goes with coinsurance. A coinsurance is usually the percent you pay. Like if you have a 10% coinsurance, that means you pay 10% of whatever the price is, the cost is of your medical care. But you show the people the word coinsurance and they think, oh, I have a second insurance coverage. That's doubly good. So if people can't understand the basics of the language of insurance, it's hard for them to make good choices. Even when we put plans and you try to simplify things and say, okay, I know it's confusing, let's have bronze, silver, and gold plans. And we try to show what the different kinds of plans are, with gold plans being higher monthly costs, lower out-of-pocket cost. People don't necessarily pay attention to that information about out-of-pocket costs versus premiums. They just look at silver and gold, or bronze, silver, and gold, and assume gold must be better. We ran a study in Durham on buses, actually, rode the buses back and forth and handing people surveys. We just switched which plan was gold. And we found that pretty much no matter which one was gold, that's what the majority of people wanted, especially the people who weren't very confident in their mathematics skills. So you can imagine people who aren't very, who don't have a lot of money to spare, come in and they get so confused by insurance, they might choose the wrong plan. So that's failure number one to me, of this idea that if we get more of a free market in healthcare in the United States with more out-of-pocket costs, we'll have empowered consumers making better choices. Well, they already start off purchasing insurance plans they don't understand, facing out-of-pocket costs then that they don't anticipate because they don't understand the plan well enough to realize they have out-of-pocket costs coming their way. So that's the first problem. Second problem is once you get that high out-of-pocket plan, ideally you should be able to figure out what things cost so you can make choices based on those costs. Instead, we have a system in the United States where prices, healthcare prices, are often opaque. And that's really an important problem because there's huge price variation in the United States. Just to give you two examples, these are surgeries. One study showed that when you looked at the price of getting an appendectomy, it could be as low as a few $1,000s to as much as $60,000. The price of a hip replacement as low as, $15,000 or $20,000, as high as $150,000, with no explanation why it was that much more expensive, and no evidence that there's a correlation between price and quality. So there's huge variation in price, probably not huge variation in quality necessarily, but there might be some. And then on top of it, people have a hard time figuring out the prices. One of my former fellows, Pete Cram, who's in Toronto now, he did a study, really brilliant. I wish I had thought of it and mentored him in it, and I could take credit for it. But he did a study where he just had his research assistants do a secret shopper study. They called hospitals around the United States, said that they had a grandmother who needed a hip replacement but didn't have insurance. They wanted to find out what it would cost to get a hip replacement there. They were only able to find out the full price of the procedure 10% of the time. And that's typically after making multiple calls to most institutions. So if you can't have a great, you don't have empowered patients by exposing them to high out-of-pocket costs and then making it hard for them to figure out the price. We actually did one study. I had a bunch of my really bright Duke undergrads, and Allison Kratka, who's now a medical resident at the Brigham. They ran a study where they just tried to Google for the price of things. They just like price of an upper GI in Denver, and they would do these kind of searches and found price information like 10, 20% of the time. They found lots of ads for companies they could sign up for that would give them price information, that when we did try that a couple times, we just got a bunch of emails that really didn't help very much. And we found it was really, really hard for a consumer to try to inform themselves about this. And even some companies that are out there that are trying to give people price transparency information, the information is often incomplete and inaccurate. And those companies have failed to thrive for the most part. There's some stuff in the margins we can talk about later. Why are prices so opaque? Why is it so hard for Americans to figure out what things cost in medical care? My wife was negotiating managed care contracts in Philadelphia a couple decades ago, and gave me some insight into that. When two of the insurance companies in town merged and then came back to the institution she was working at and said, we now want the lowest price that you negotiated between the two of us across the board. Ended up in a lawsuit. But what it also proved is that an insurance company negotiating with a healthcare provider doesn't want another insurance company to know the price they got. And the provider definitely doesn't want to know. If I give a discount, if I, Duke University, give a discount to Blue Cross Blue Shield because they're really big and powerful in town, when Aetna comes my way and they don't have as much market share, I want to be getting a higher price from them. I don't want them to know the price I just got from Blue Cross. And so because prices are often set because of negotiations between payers and providers, nobody wants those prices out of the dark. All right, so that's two problems we talked about. People don't understand the insurance they buy. They end up then sometimes in high out-of-pocket plans and then can't even find the price of the care that they need. Here's a third problem. Who's making the medical decision about what people get in the first place? I go in and buy a cell phone. I'm the one, my wife, deciding who gets that cell phone. But who's the consumer in medical care? Often I think it's the physicians who make the choice. We did a study, this is led by Angie Fagerlund, who's now in Utah, where we gave a decision aid to men with early stage prostate cancer to inform them about their treatment choices. We did some survey work. We found that based on what they cared about, things like preserving sexual function, fear of bladder dysfunction, things like that, you could see some people leaning towards more aggressive care that had those side effects and some avoiding aggressive care to avoid those side effects. So that's what they did after the decision aid. When they finished seeing their physician, however, there was no longer any correlation between what they said they cared about and what treatment they got. And it's because, and we audio recorded about 300 interactions. When we looked at the interactions, we found the dominant thing determining what treatment people got was the physician recommendation. The physician sometimes making it sound like one of the treatment options wasn't even an option because they were the medical expert. And so even though they're trying to empower patients, they're often telling them a lot about each of the three options. They then shade that information with often really strong clinical recommendations that what patient would reject that. And so because consumer markets, typically it's the consumer making a decision, and the consumer knows the price because it's right there on the price tag. They might be able to find out the quality by just looking at Yelp reviews. You can imagine there's a lot of pressure to lower costs and raise quality. In healthcare, they can't figure out the price in advance. And it almost doesn't matter because they're doing what the physician tells them to do anyway, in many cases. So that's the third problem. Here's problem number 4. This is really depressing. I'm sorry about that. There are times where physicians try to engage in cost talk with their patients. Sadly, it doesn't always go as well as it should. I did some research with a company called Verilog. They're a marketing research firm. I did not get any money from them. They were generous enough to share some of their data with me. They audio record and transcribe encounters between clinicians and patients. And they gave me access to 2,000 interactions between patients with things like rheumatoid arthritis, depression, and breast cancer. And so we had 2,000 transcripts of doctors and patients interacting, and they were recorded with their permission and all that. All the information was de-identified, it was anonymous. But they were just having routine interactions, and we got to look and see how often costs came up. We found that cost talk was quite common. About a third of the time, there was some discussion of out-of-pocket costs during the clinical interaction. And that's just a random interaction between a person with breast cancer or rheumatoid arthritis or depression and their clinician. We found those discussions were especially common in the psychiatry visits. And I think as geriatricians, you probably would have been very close to them in that, because what we found is that the psychiatrists would be trying to just understand people's life really broadly. And they try to figure out, what kind of stress do you have at work, at home, in your relationships with your children? How about financial stress? And when they just ask routinely about financial stress, patients would often say, well, paying for your medicines is pretty hard, or, it's expensive parking at this dang hospital. And so by asking about finances, often healthcare costs came up, and then they had conversations about that. So that's great. We're having some discussion of costs. There are a lot of times that productive things came out of those conversations, and a decision to have a telephone visit rather than have them come and have to travel and park again, or a suggestion for a discount pharmacy where they could get the same medicine less expensively. Things like that came up. That was great, but often there weren't very productive conversations about cost, in part because the physicians couldn't figure out the costs either. That price opacity came back and hit them too. And often because they were so confused by what kind of insurance coverage somebody had and what was covered and what wasn't covered, that they couldn't come to an answer. And I'll give you a few quick examples of some of the times where the cost talk didn't produce the kind of great cost-quality trade-off decision-making you'd hope it would. There was one time a patient came in and complained about the cost of a drug called Nexium for their ulcer. And they said that was very expensive. This is a patient with rheumatoid arthritis who was having these stomach problems. And the doctor basically just said, may have been looking at the computer, I'm not sure, and then turned to the patient and then started talking about the drug for their arthritis. Never addressed the fact that the patient had complained about the very high out-of-pocket price of an ulcer pill where there's much less expensive alternatives available. So the patient ended up leaving that visit still on that expensive medicine, no discussion of whether there were better alternatives. Another time a patient came in and said, I'm just gonna look down and read this. I'm drinking a nutritional supplement I'm supposed to take every day. The doctor says, but I try to stretch it out because it's a bit expensive. I'm imagining the sound of typing going on here. So anyways, I'm developing anemia. I'm having to eat high protein food right now. And this is a patient who had cancer. They were losing weight. They needed nutritional supplement quite badly. It's a tragic story to hear, and they're having a hard time affording this. At the end of it, they basically continued to complain about the cost of this nutritional supplement. And the doctor says, and then says, let me look at that spot, and then starts examining the patient, basically ignoring their financial concerns. Sometimes there's not, the concern is out in the open and it's not ignored. Instead, it just leads to this robust conversation about how much the US healthcare system stinks. Whereas a patient will talk about how the insurance company won't even cover that. And the doctor says, oh my God, I know they don't cover everything. They barely pay me back in time. And the doctor complaining about their own payment. And then the patient going, I know, I hate insurance companies. And then the doctor, yeah, in fact, did you know the CEO of such and such company just made this and this much money last year? They bond. It's a wonderful bonding moment. You can see how much they're enjoying going after insurance companies together. But then at the end, they forget to go back to the fact that the patient had high out-of-pocket costs and was frustrated and disturbed by them, and they never addressed those costs. Sometimes cost concerns are actually just dismissed out of hand. One patient came in and with a newly diagnosed breast cancer, the doctor recommended they get the BRCA genetic test, which is a good thing to do at that stage and helps determine future risk and what the best intervention is. The patient then asks, well, how much is that genetic test going to cost? And the doctor says, oh, we don't want to talk about that. Well, no, we did want to talk about that. The patient did want to talk about it. And I think the doctor, in dismissing it, was really trying to say, it'll be covered, you should be fine. But that's not necessarily what the patient heard. What they might have heard was, uh-oh, I'm not supposed to bring up money. And many times people with breast cancer end up unable to afford their therapy or having to decide between their therapy and their mortgage. And they often don't talk to their clinicians until they're in dire financial straits, which is then too late for them to undo some of the financial damage that's already happened. And if this kind of signal is happening early in care, it seems to only make it more likely that the bad things will happen later. I'm going to give you one other example of this communication breakdown. This was a patient, another patient with breast cancer who had a metastatic disease to bone and a lot of pain, was getting OxyContin for that and was discussing the high price of that pill. And the doctor basically suggested, despite their pain relief not being adequate, that they should just take the pill less often, then it'd be less expensive. Never considered a less expensive, probably equally effective long-acting narcotic. And in fact, there are other pain modalities that probably should have been talking about. So just tragic. We need to do a better job as clinicians of identifying when our patients are getting financial toxicity from the treatments and then seeing if there are alternatives for them. All right, continuing with this depressing take on the world. I've talked about 4 problems. The 5th problem I'm going to talk about is really taking all those other problems and putting them at the end of life and just watching how much harder they make things. Imagine that you have a pill. You have cancer with a decent prognosis, but you would like to have a treatment that would make the prognosis better. And you have a 52% chance of surviving for another 5 years with the cancer. But a pill would increase that to 56%. How much would you pay for that pill? You can think of a number, how much you'd pay per month to take that pill, and it'd be a decent amount. I mean, that's a 4% absolute increase in survival, and that's a good thing, assuming there's not a whole bunch of side effects, etc. Now imagine instead you have no chance of surviving for that long, it's a uniformly fatal disease, but have a pill that gives you a 4% chance of surviving. That feels very different. It's the same 4% increase, but now it's taking me from no chance of survival to some chance of survival. That is a really big difference. And many times when we're near the end of life, that's the way our minds work. We are thinking, well, I could go to the ICU. That's a miserable place. It's expensive. It's all this. But if I don't go there, it's over. And so when seems like there's nothing to lose, that's not when people are going to be great at scrutinizing the price and quality of care. That would be my just suggestion. All right, so there's some of the problems I'm laying out all too briefly and all too depressingly. And I want to remain brief, but I don't want to be depressing. So I think that there are things we can do that will make this better. I think of it as a recipe. there's no single ingredient, single thing we can do that would fix all these problems. And I'm not even sure the right mixture of them we should put together, but I'm going to give you some things we could mix and match and cook and simmer and stew. And I'll try to end that metaphor and tell you what I'm talking about. Okay, so first thing we need to do is make sure that we don't try to empower people by simply exposing them to high out-of-pocket costs when they don't have the financial resources to absorb that kind of blow. In Singapore, which is a medical system that does have a lot of out-of-pocket costs for a lot of the medical care, and there's a culture of recognizing that you're going to have to pay something for anything you receive. There's a lot more frequent discussion of costs. There's a lot more knowledge about costs, but also people who are really low income, they get money put into a supplemental account that they can use to spend on their portion of the medical bills. And so we have to recognize if we're going to have a policy that gets more and more Americans into high out-of-pocket plans, those who are low enough income should get some kind of subsidy that they can use just for medical care, something that we roll over year to year that would help them afford any out-of-pocket costs that they incur. Second thing we need to do, we need price and quality transparency, and I think that needs to be legislated. Providers and payers are not going to make this information available on their own. There are some states that have legislation. Most of it's pretty ineffective. And when there's outside groups that have rated it, I think one state, New Hampshire, gets a grade of A for their price transparencies. Most states get grades of F. I think Colorado might be in that camp, but I'm not sure. But I think you need to regulate this and just make it mandatory that this price should become available. And I think it then needs to be put into a user-friendly form. In New Hampshire, where they do have this regulation, you can go onto the New Hampshire website and you can just say, what's the price of an upper GI? And they will list all the prices by alphabet, by zip code, by most expensive to least expensive, by least expensive to most expensive, based on your own coverage. They'll show you what your out-of-pocket costs will be, and you can be informed about that. And then they put some quality information there too. That's imperfect information. It's hard to know how people will process it. I think there's a great research we could do on how people process price and quality information, but we can't even do that research if people don't have that information. So I think that's an important thing to do. So that's two things I've said. Let's give them money to afford out-of-pocket costs if that's the kind of insurance they're going to get, and we need to give them price and quality information. The third thing we need to do, I think, is we need to redesign out-of-pocket expenses so that they reflect value. This is an idea that Mark Fendrick and Mike Chernow at Michigan and Harvard, respectively, have called value-based insurance design, or VBID. The idea here is don't have out-of-pocket costs go up just because prices go up. Because sometimes there are high-priced things that are really, really effective, and we should be encouraging people to take them. Think of biologic therapies for things like rheumatoid arthritis. Sometimes there are things that are inexpensive that are useless. Why should those be cheaper? And people should be paying a lot out of pocket for that, or they should be bearing most of that cost. And so the idea of a value-based insurance design is, as the value of a treatment goes up, of an intervention goes up, so that's the value in terms of, say, how cost-effective it is, how much health benefit it brings for that price. As the value goes up, the out-of-pocket cost should go down. As the value goes down, the out-of-pocket cost should go up. And I'm using the right finger here, so I'm not flipping any of you off. So I think that having more rational out-of-pocket costs is a way to just signal to people, this is really cheap. So there's no barrier to getting it, and people are more likely to get it, and that's good. And when something's expensive and they're like, uh-oh, I better think about that. Well, we want them thinking about it because maybe it's not such a great way to spend anyone's money. Another approach that's different than this VBID approach, but also has shown promise, is something called reference pricing. I'll just return to hip replacements as an example for that. You go, say, the state of California had a bunch of their employees who would need hip replacements every year. And some of them would go to the doc that cost $28,000. Some would go to the doc that cost $45,000 or $59,000 or whatever. And the state thought, that's a hell of a lot of money we're spending on high-priced providers, and the patients are all just paying, $200 out of pocket for a copay or whatever it was. So they switched it up, and they told everybody, after looking at what the price points were and where they could find high-quality providers at what price points, they said, we will give you $30,000 for a knee replacement, up to $30,000, excuse me. If you go to a provider that charges more than $30,000, you are welcome to do that. You will pay the difference. You will pay anything that's more than $30,000. Two things happen as a result of that. First is, a lot more people went to the providers that were $30,000 or less. They did, when they were made aware of this, they started looking around. Second thing they did, a lot of providers brought their prices down from $38,000 to $29,000 to get more business. Fifth thing I'm going to suggest here is that we just need to simplify insurance. There's too many choices that people don't understand and don't make good choices anyway. I actually think high deductibles should be removed as a choice. I don't think they benefit anybody. Instead, high deductibles typically discourage people from getting appropriate medical care. And so I think we should simplify insurance, and we should have a big emphasis on the kind of quality of care people get and on minimizing out-of-pocket costs for high-value services. And the final thing I'll suggest, we need to be more creative about how we spend healthcare dollars. There are a lot of things that aren't traditional healthcare that can bring as much or more benefit than more traditional healthcare. In the United Kingdom, socialized healthcare system, they're using National Health Service dollars at the end of life for people to have more flexibility about how they use it, even partnering with their clinician. And in one example, this was written up in The Guardian, of a man with Alzheimer's whose family used some money to buy a DVD player that they could take his favorite game show and record it and then just play it repeatedly to calm him down. And he could watch the same show multiple times and not remember it. It's sad, it's tragic. But that DVD player did more to calm him down than any medication probably would have done, and with many fewer side effects. So that's really my thoughts. I think we have pushed people into high out-of-pocket plans in the United States without thinking about whether the system is ready for them to make the kind of wise choices that such plans demand. And I'd like to see us be smarter about it. So those are my thoughts. I'm really eager to hear yours. And so I'm opening up to any questions you have. Thanks.
Thank you, Dr. Ubel. That was a great talk, very interesting and thought-provoking. So a couple questions. Well, I see one in the Q&A box here. And I don't know, I can read it for everyone. So should the system at some high level make decisions about marginal benefit treatments and not even make them available? For example, some new cancer drugs that are fourth or fifth line salvage agents with less than 10% additional response, remarkably high costs. In my ideal world, the questioner says, Sloan Kettering and MD Anderson would take the lead and decline to offer barely effective, super expensive agents.
Yeah, that's a great question. And I didn't talk about the idea that maybe we need to have value-based pricing. That's another thing I wrote about in the book. And that would be that for a new chemotherapy that comes to market, there would be some kind of regulation that it has to be priced to reflect how much benefit it brings. And so if it's, right now you have a lot of chemotherapies that come to market, $100,000 for the course of treatment, that's the magic number. It has to be more than $100,000. And they'll bring a median life expectancy gain of 2 or 3 months, which amounts to really poor value. And value-based pricing would just simply say, if you want to get coverage for this by Medicare, and trust me, private insurers would follow very quickly if that was the case. If you want to have this covered by Medicare, you need to come in at this many dollars per quality adjusted life year or less. This is what they do in Australia and the United Kingdom. I think would bring prices down. And if companies don't bring prices down to that value, I think one option is to say we don't pay for it. And of course, that just means people can pay out of pocket on top of it, so you're not denying them that drug. You're just saying that we're not going to reimburse it. It'll be on you. It's cruel, but it's probably crueler to have this kind of money spent in ways that don't bring much benefit.
Thank you. Another question, are there any examples of pilots of value-based insurance design that you're aware of?
Yeah, there has been some research on it, and it's been underwhelming. There are studies that I know best of are done often in diabetes care, heart care, things like that. And of course, some people would suggest that the Affordable Care Act has built in a whole bunch of value-based insurance design by mandating that preventive services that are approved by things like the Preventive Services Task Force should be offered to people with no copay, so you can get colon cancer screening for free, for example. And we've seen increases in colon cancer screening as a result of that. So we do know from these pilot studies and from what's happened in the Affordable Care Act, you lower the price of these things and people are more likely to receive those services. What we haven't, it's been asymmetric though. We haven't had a commensurate increase in out-of-pocket costs for low value things like what the first questioners had talked about, some of these really expensive chemotherapies. Politically, it's way easier to say that we're gonna give things for free and the drug companies know they have more business. It's hard to say for other drugs, we're gonna have people pay more out of pocket. That is politically difficult.
All right. Another question, comment. So clearly legislation is necessary to move our healthcare system to something that's more sensible in the long run. What are patients supposed to do now to gain better price transparency and navigate the confusing system? They comment, right now it seems easier to become an expat in a country that has figured this out.
I think that I've been talking to a lot of clinical groups about what they're currently doing to try to address these out-of-pocket costs and help their patients navigate the system better, and what they could do. And it is a mess and it's difficult. I think that some places I've talked to are screening patients when they come to the clinic to see if they're having high out-of-pocket costs that they want to talk about, because you can't start addressing them if you don't begin talking about them. Now that can lead to a conversation that's difficult. But the nice thing is healthcare is a team sport. So the physician or the nurse practitioner might not know the out-of-pocket cost alternatives right there on the spot. Maybe they can refer the patient to a clinical pharmacist who can. Or maybe they can write 2 or 3 prescriptions and just say, find out what your insurance covers and pick whichever one is more affordable. So it's imperfect, but maybe that kind of a combination of screening for financial distress and then partnering with other people in the clinic can make the problem less bad.
Thank you. That kind of answered another question that was advice for clinicians about how to address costs when they're brought up in clinic, especially when we have no idea what things cost. So that was helpful.
I will say a lot of times patients know more than you think. And so sometimes they've figured out certain things and they can help you with that. Like write the prescription here rather than there, or send a 90-day rather than 30-day. They're often really creative about that.
Another question, so with respect to the ideas that you've raised today of how to improve things, are decision makers listening to these ideas? Do you have the ear of the folks who are making decisions?
Well, there has certainly been an increased amount of attention to out-of-pocket costs, to high prices, but it hasn't led to a whole lot of great policy. I'll give you one example of that. There was a really intelligent legislation that was being put together to address surprise billing, which is a name that refers to I go in to get a surgery and I know the price, except there's an assistant surgeon who's out of network that nobody told me about, who sends me a separate bill. Or I go to an emergency department that is out of network and they send this huge price, or it's in network, but again, the provider is somebody that they brought in to cover the night shift and they send me a separate bill. So these surprise bills can be enormous. And there was great legislation to just set caps on how high those bills would be. And then very strong lobbying efforts came from what looked like physician groups, but were actually private equity people that had bought up physician groups that staffed things like emergency rooms with their business strategy being, let's increase surprise billing. And that lobbying basically kept that legislation from happening. And we need to go back and try that one again.
Thank you. All right, any other questions coming in?
I'm curious to hear what people what they're struggling with, what they encounter. My take on geriatricians, I think, are so much more holistic than many other types of providers. I know way more aware of polypharmacy and the harms it can cause. And I think traditionally that has been all the side effects you can get from polypharmacy, all the difficulties to remember what pills to take when and where and all that. But I'm sure you're also probably at the forefront of realizing that there's a financial cost to being on all those meds. So I'm curious to see if people have themselves developed strategies for navigating this.
I'll just say, personally in our clinic, kind of what you had mentioned in some of the advice is that we're fortunate to have a clinical pharmacist, clinical geriatric pharmacist in our group. And I found them incredibly helpful when a patient comes and says they're having difficulty with such and such medication, in really exploring, calling the insurance company, figuring out would there be a better, less expensive alternative, and also helping with patients who have found themselves falling into the donut hole. So they've been going along okay, and then towards the end of the year, all of a sudden they're really struggling. So I would just say our pharmacists in clinic have been really helpful with that.
That's great to hear. That's great to hear.
A couple other questions here. So someone says that I find that helping patients navigate the Medicare marketplace alone is one of the most complicated things. So fee-for-service versus Medicaid Advantage versus supplemental plans. And I found the state health insurance assistant programs are a great resource as well. So thanks for that.
Yeah, it's great advice. And you're right, just that choice alone is overwhelming.
And then someone else also commented, again, pharmacists, and then our social worker. We have a full-time social worker in our clinic, are extremely helpful. Social workers helping with some of the other costs that people struggle with in our clinic. So we're fortunate.
Yeah, so just a quick aside, many people will use the phrase single payer plan and Medicare for all as interchangeable, but that comment reminds us that those are two different things. If we went to Medicare for all, which would solve some problems, right? But if we went to Medicare for all and the way Medicare currently is, we'd have all kinds of payers still, because it's like 40% of people are in Medicare Advantage getting it from private insurers. And then there are people who get traditional Medicare but get supplemental. So there's in fact tons of payers. So single payer is different than Medicare for all. It's just a reminder when we have our debates with our crazy uncles.
Good point. And another comment is one benefit we have as geriatricians is that all of our patients have Medicare. And even though the drug costs can certainly be variable with Medicare D, at least they have coverage that's relatively predictable through Medicare.
Yeah, that's a really good point. That's a really good point.
And then another question is whether you have an estimate of what proportion of the healthcare system is controlled by private equity firms.
Oh, I don't know. I think, first, I don't know what I mean controlled by, but private equity is a niche part of medical care right now. There's certainly a lot of for-profit aspects to even healthcare providers. There's for-profit hospitals and things like that. But private equity, I think, is working mainly on the margins, but it's also increasing.
Okay, so here's another comment. We're in a field with little or no developments of high-value interventions. Thus, the focus on deep prescription in nursing homes and assisted living facilities. So in a sense, we've been leading the charge, is the comment.
Yeah, there's still, certainly for things like dementia, we don't have great, really highly effective therapies. But I just want to be clear that there's a difference between highly effective and high value. So something could be a little bit effective and kind of inexpensive. That's high value. So I think a lot of what geriatrics does is high value. It's even just trimming down the number of medicines someone's taking and avoiding side effects that might lead them to be more likely to fall. That might not slow down the progression of their dementia, which we hope to be able to do someday, but you might be preventing a terrible problem happening. That's high value care. I think most of what geriatrics does, I would think of as high value care.
And then someone asks whether there are causes or lobbying groups that we can support and advocate for changes in the healthcare system.
Yeah, I think it's good to look at your own professional organization and what they're doing, the professional organizations you belong to. So there's geriatricians there. I don't know what the name of if it's American Geriatric Society or whatever, but there's the American College of Physicians and the AMA are the other organizations that are all relevant. And I actually think they're being pretty enlightened about the kind of things they're pushing for. There hasn't been a ton of emphasis on some of this high out-of-pocket plan things that are happening, especially for people with insurance through their employer. think there's so much battle over the Affordable Care Act, and we'll know in a few weeks whether that even exists anymore. So I think this is going to be harder to push for, but I do think most of those professional organizations have been pretty enlightened lately. It's not the same old AMA even that it used to be.
And then what is your opinion about whether or not most people will have a personal physician in the years ahead who sticks with them over time?
I don't know. It's certain. I mean, I think that's a higher way. That's a better form of care, and I think the idea that people switch insurance plans year to year to year makes it hard to stay with the same clinician. That's less of an issue once they reach age for Medicare. But yeah, I'd love to see payment reforms that emphasize the importance of continuity and that give people an incentive to stay with good providers longer.
All right. Any other questions or comments? Parting points? I don't see any more questions coming in here. But.
Well, I want to thank you for being 2 hours in the right direction from me. I got a panicked email a week ago saying, "Oh my gosh, we just realized you're going to have to give a talk at 5:30 in the morning." I'm like, "No, it'll be 9:30 here. I'll be good." So phew, we're all better off for that.
Right. Well, thank you again so much. This was a really fascinating talk and some good Q&A. I wish it could have been more interactive, but
Absolutely.
Have to have you back at some time when we're able to do that again.
Love to do that. Love to do it.
Yeah, we'll send out the information so people can look at your blog and other publications and the work that you've done. So
yeah, if just 2 of you buy Sick to Debt, you'll bring me into double-digit readership. So
wonderful. All right, thank you so very much again, and yeah, thanks for joining us. Take care.
Have a great day.
All right, bye-bye.